Good morning, everyone. I'm very conscious of time, so we'll kick off. My name is David Neville, Chief Executive with InvestNet and founder of the Future Health Summit. I'd like to wish you a very warm welcome, and warm is appropriate this morning, I think, to the Future Health Summit 2026. For over 20 years, this summit has brought together international and national health leaders from across the health system, clinicians, innovators, policymakers, researchers, and industry partners. Our hope has always been by creating a space for honest discussion, shared learning, and new connections, we help drive meaningful progress across the health agenda. It's a pleasure to continue that tradition this morning. This year's programme reflects a system moving forward with purpose, advancing digital capability, modernising infrastructure, improving patient experience, and building a more connected, data-driven ecosystem. Over the next 2 days, you'll hear from national and international voices driving meaningful change across hospitals, community services, and research and innovation. Before we begin, a few quick housekeeping notes. This year we've developed a dedicated Future Health Summit app. The details are on your badge, so scan the QR code and that'll give you access to all the delegates attending, speaker details, exhibitors, sponsors, and also will allow you to ask questions to the speakers over the 2 days. The secure key is Summit 26. Again, all these details are on the front of your badge. There's also a couple of competitions to avail of over a couple of days. We have our exhibitors competition. If you visit the exhibitors through your app again, you can get a digital stamp on your app, and obviously the more stamps you get, the better chance you have of winning. This year's competition is sponsored by Midland Escape. It's an incredibly generous prize. It's corporate wellness team building experience for up to 10 people, including kayaking, paddle boarding, cycling, and team building activities valued at €10,000. Harmony Healthcare IT also have a competition running. They're our coffee break sponsor over a couple of days. Details of both of these competitions are on the app. We have a drinks reception this evening that's sponsored by our partners, Top Doctors. That's taking place directly after the final session outside of the exhibition hall. Everyone's welcome to attend that. If you're posting on social media today, please use the hashtag FHSummit26. It's now my pleasure to introduce the person who will be chairing proceedings over the next couple of days, Dr. Tom O'Callaghan. Tom is a committed family doctor and medical education entrepreneur with over 30 years' experience. He has built international medical education partnerships across Europe, the Middle East, Asia, and Africa, supporting the development of highly skilled and compassionate healthcare professionals. He is also medical director at Atlantic Healthcare Alliance, a new GP network in Ireland. Please welcome Dr. Tom O'Callaghan. Thank you.
David. Thanks, David, and welcome everybody. It's great that so many people turned out on such a beautiful sunny day when you could be going to Britas Bay or somewhere like that. They say when we start these conferences now, we should always ground them in a patient story. And I know when we're talking about system redesign, it's great to go to a meeting and everyone's talking about all the change and everything that needs to be done, and then someone says, where's the patient in all of this? So I thought I'd tell the story about two friends who met at a funeral down the country of their dear friend, and they were standing looking into the coffin, and one friend said to the other, it was so sad that he died simply because nobody knew his blood group. And the friend said, it is, but isn't it incredible that his last inspiring words were, be positive. So what I'd really like out of the next couple of days is that we focus on the positive. We've so much to be positive about. And we're going to hear from some amazing and really inspirational colleagues and leaders in the healthcare sector, both here and abroad. And I know we all live in times that are where we kind of need inspiration, where there's a lot of uncertainty, from conflicts and economic crises to climate change and aid cuts. We live in difficult, dangerous, and divisive times. They're not my words, they're the words of Director Tedros this week on Monday at the WHO, and I know we're going to be joined by Mike Ryan tonight and tomorrow, and he'll speak a little bit about that. And we can all see the impact in our own lives with our children and our friends of social media and the isolation that's creating in the younger generation. And we see political leaders cheerleading inhumanity, promoting greed and indifference towards the most vulnerable people in our society. And I think in Ireland we have a long track record of not being like that. And I think we'll continue that, and we're going to hear from people today who firmly believe in that. And yet the advances and opportunities of technology and new treatment modalities are incredible and moving at breakneck speed. And it's just, we've all seen it in different areas of the healthcare service. And we're going to hear it today, the use of AI and big data and the impact that is going to have in terms of longevity and reduced mortality. And we've a lot to be proud of in Ireland over the last 10 years in terms of the data of our own morbidity and mortality statistics. And we don't hear enough about that. We're now second longevity within the European Union, which is incredible in the last 10 years. So there's a real need for inspiration and kindness, and I think particularly empathic leadership. And we're going to hear from many today who I know have those qualities and been chosen to be here for those very reasons. And we're also going to honour the life work of a number of really, truly remarkable healthcare leaders, both in Ireland and internationally. And the impact they've left with their patients and their communities, I think, gives us an inspiration to do better. And that kind of leadership takes courage. I know everybody cites Jacinda Ardern as one of those empathic leaders, the previous Prime Minister of New Zealand. And she said, "I refuse to believe that you cannot be both empathic and compassionate and strong." And I think that's the space we need to occupy. And Simon Sinek reminds us all that the real job of a leader is not to lead or be in charge, but it's taking care and lifting up those people who are within our organization and allowing them to grow and shine. So over the next 2 days, we're going to hear from the new CEO of the HSE, Anne O'Connor, and we obviously all wish her well in that role. Tim Mackey, who's at the end of his career in the NHS. We're going to hear shortly from Derek Tierney. We'll also hear from Colm Henry, the clinical officer in the HSE, and we'll also hear from Mary Horgan of the Department of Health. We'll hear from Enterprise Ireland, the Health Research Board, ESRI, and many, many more organisations. We'll talk about AI, digital health, women's health, equitable access, and what it really means to build a sustainable healthcare system over the next 10 years for our families and our communities. So in the first speaker up this morning, we wish him real, sincere good luck in his new role. We need brave and strong civil servants to lead our healthcare system, and Derek is definitely one of those. He's recently been appointed Secretary General of the Department of Health and brings over 30 years' experience across wide levels of organisation, both public and private sector, including government departments and state agencies. He holds responsibility for healthcare infrastructure, including ICT and digital health, and he was the programme director of the government's COVID-19 task force and has led whole government responses to Brexit and the mortgage arrears. So he knows a thing about building stakeholder coalition, making hard choices and pushing people to do their very best. So I'd ask you all to welcome Derek to the stage.
Good morning, everybody, and thanks, Tom, for the warm introduction. So for this morning, just let me start with a question, and it's not for reflection later, it's really for now. And I suppose the question I want to pose at the outset is, are we fixing a system under pressure, or even trying to fix a system under pressure, or are we prepared to redesign it for a world where pressure is the norm? Because to me that distinction matters, and it matters because in truth, pressure is no longer a phase we're moving through, it's the environment we're operating within. As Tom said, Ireland's health system presents a paradox. We now have the best, or one of the best, health outcomes in Europe. Yet the lived experience for lots of our patients doesn't always match that success. We see waiting time to access services, fragmented pathways, and processes built on paper. And that's in a system that's delivering world-class clinical care. So let me pose a second question. If outcomes are strong, but the experience is not, what does that really say about the system we have built? Because what it says to me on reflection is, we have a system that works very, very hard, but not always coherently, and that's the challenge. Traditionally, we've talked about pressures in isolation, waiting times to access services, or workforce shortages, or infrastructure gaps, or even funding constraints, but that's no longer sufficient. What we are seeing now and managing is something fundamentally different. A system where pressures are arriving simultaneously, reinforcing each other, and accelerating faster than our ability to respond in individual silos. So geopolitics is translating into energy shocks, and it's disrupting complex global supply and logistic chains. We can see now that economic conditions are starting to tighten fiscal headroom, while our changing demographics are just increasing demand day on day. And technology, particularly AI, is moving faster than governance frameworks can adapt. So I think the real question is not what is going on or what's even wrong. It's what's happening when multiple risks move at once, and are we governing for a reality, or are we responding with the same level of system thinking? Because that's the shift from isolated pressure to converging system risk. As Secretary General of the Department of Health, my role is not to directly run health services, but it is to steward a wider health system, to provide assurance that government and the public have confidence that we're delivering safe services and value for the taxpayer, that all our risks are understood, and that delivery aligns with policy intent. But stewardship in today's environment is more demanding than it ever has been, because I must, and we must collectively, provide credible assurance in constant pressure, drive reform while maintaining stability, and operate in a highly scrutinised political and public environment, and prepare for shocks that we can't even see or predict. And perhaps most importantly, we must bring coherence to complexity. So now the leadership question becomes, how do we lead reform at pace without destabilising the very system we're trying to improve? And despite everything I've just said, there is a reason this summit is not called from pressure to crisis. It's deliberately called from pressure to progress, because that's a deliberate choice. And there's something else in the system right now, and that's momentum. We have a public that's more open ever to change and digital engagement. We have record levels of investment in infrastructure and capacity right across our health ecosystem, and new care models are taking hold. In the public sector and the public service, we see surgical hubs now starting to switch on to protect elective care. We're introducing virtual care to augment physical capacity, and we're seeing new ways of working, including integrated services and whole-scale investment in community services, health prevention strategies, extended and weekend working from our public-only consultant contract, a move to 5/7, and a clear reform direction under the umbrella of Sláinte Care. So we're not starting from zero. We're starting from a position of both pressure and possibility. And so the real challenge is, can we convert that pressure into disciplined, sustained progress? But if pressure is converging, then our progress must be systemic. And I would suggest that there are 4 shifts now that we must take. The first shift is moving from activity to outcomes. We cannot continue to measure by how much the system does in terms of activity. We must be clear about what it delivers. Shorter wait times, better outcomes, improved access, and better patient experience. And underpinning all of this is public funding, and that requires consistent assurance, transparency, and compliance. And these are non-negotiable to assure both taxpayers and patients that our funding translates into safe care, efficient performance, and transparency. Because ultimately, activity without outcome is not progress. The second shift I would propose is from fragmentation to integration. We're all still too often organised around care settings, institutions, rather than patients. But patients do not experience the system in parts. They experience and they expect it as a journey of care. So now the question becomes, are we designing services around people or expecting people to navigate the service? And Sláinte Care for me sets the direction. Right care, right place, right time. But delivery requires alignment and integration across structures, funding and behaviour, with the patient at the centre and dignity and compassion to the forefront of their experience. The third shift is about advancing patient-centred care in the digital age. Let me be very direct about this. We cannot build a sustainable system on paper. The opportunity of digital is not just technology, it's about redesigning and reimagining care. But that also requires discipline. And Digital for Care in our Irish public health system sets out a clear ambition to do this. It's about connected care, shared records and electronic health records spanning a life journey, data-driven decision-making, empowering patients, and a digitally enabled workforce and workplace. And we have already seen what's possible. We're seeing the health app and its functionality really now emerge, shared records emerging to empower patients and our clinicians, virtual wards expanding to augment our physical capacity, and intelligent automation and AI beginning now to support clinical and back office workflows. But here's the question now we need to confront. Are we digitising what we do today, or are we redesigning care for tomorrow? Because they're not the same thing. The fourth shift I propose is moving from managed pressure to strategic investment. Every health system, no matter where it's located in the world, faces financial constraint, but not every system uses it strategically. Therefore, we must constantly ask, are we investing in just what reduces pressure, or are we simply funding how pressure presents? And that applies to service planning, workforce planning, capital investment, digital infrastructure. But sustainability is not about spending less, and it's about spending differently with intent and discipline. So whether that means delivering more with the same or less, or the same with less, it does mean tightening performance grip and financial grip, reducing variation and duplication, and going after productivity at the bottlenecks within our system. So no discussion looking into the future is complete without addressing AI. We're already seeing this. Our clinicians are using AI tools in daily practice to support their decision making. Patients are using AI as a first point of contact in terms of their own self-diagnosis. And innovation is accelerating at pace, and at a pace we haven't experienced before. And it's not theoretical, it's happening today. But with that comes a profound governance challenge in my view. So the question is not, will AI change healthcare? It already is. The question is, will we shape that change or will it shape us? Because if we get this right, we will give clinicians time back to give to their patients. We'll enhance patient pathways and we'll deliver better outcomes and we'll improve productivity. But if we get it wrong, we'll introduce new risks, we fragment care further and we'll erode trust. So leadership in this space is not optional. I believe it's essential. You'll hear later on today, and particularly in the next panel, a real perspective around, and I think we've entered one of the most significant investment phases right across the health system, and an investment phase that we haven't seen in decades. We've seen record levels of recruitment, record levels of investment in our services, whether that's new hospitals, surgical hubs, expanding capacity, digital health, and the list goes on. But there is a fundamental test. And I go back to the theme of the conference. Are we really building for today's pressure or tomorrow's model of care? Because these decisions will shape the system for generations, and there's no easy reset once they're made. I suppose finally, let me turn to what I believe is one of the most important assets in our health system. And it's not infrastructure, it's not funding, it's not technology, it's trust. It's trust between patients and clinicians, the public and institutions, and the system and government. And we should be clear about this. That trust is now actively contested. Disinformation, digital channels, and social change mean trust can be eroded faster than we can rebuild it. So a fundamental leadership question for all of us now is, how do we sustain that trust in a system that's under sustained pressure and change? Because without it, no reform will succeed. So what does from pressure to progress really mean? It doesn't mean pretending pressure doesn't exist. It means doing three things differently in my view. It's about facing reality honestly. It's about making deliberate choice and not incremental adjustment. And it's executing with pace, discipline, and accountability. Because the truth is, progress is not automatic. It's the result of decisions. So as a final provocation for today, let me leave this with you as I wrap up. We'll hear many ideas and perspectives over today and tomorrow, but progress will not be determined by ideas and perspectives alone. It'll be determined by choice. So I would ask each of us, whatever our role is in the wider health system, to consider the following. What choices are we making today to genuinely improve outcomes for our patients, not just increased activity within our system? Where can we truly collaborate differently across organisations, sectors or disciplines to remove friction and improve the patient journey? What complexity are we adding to the system or the patient simply that we don't need to do? And where can innovation, data or technology be applied, not as an add-on, but as a way to fundamentally improve how care is delivered? And lastly, how do we ensure that changes we pursue, whether that's clinical, operational or technological, make the system more sustainable, equitable and resilient over time to the pressures that we're going to face? Because progress isn't created in conferences, it's created in our choices. And if we get these decisions right, if we combine ambition with discipline, reform with delivery, and if we protect what matters most and change what we must, then this decade won't be defined by pressure, it'll be defined by true progress. And that will deliver a system, in my view, that's sustainable, trusted, and a system that delivers consistently for people it serves in the right place at the right time. And that's the opportunity ahead of us, and I think that's the responsibility that sits with all of us. Thank you very much.
Thanks, Derek. It's great to have somebody who's willing to stand up and be very clear about where he wants to go in his role, and clearly looking 10 years into the future and that shift we need to make, and how we need to prioritise certain areas. And there's no doubt that the money has been spent in the last 10 years. I see it myself when you go out, and I hear it from patients every day. There's a much better level of service in so many different areas, and now I think it's about just being more efficient. The next task of the day is very close to a lot of our hearts, and it's to honour our friend Fergus Clancy with the Fergus Clancy Healthcare Leadership Bursary. This is the second year of the bursary, and last year we were delighted to start it. Fergus was a man who showed great ambition, passion and determination and leadership in the healthcare system, and I think he'd love to be here and part of this discussion today. And today we think of his wife Diane, his son Sean, and his daughter Ellie, who got engaged during the week. The scholarship provides that opportunity for somebody who's working within the healthcare system here in Ireland to take a full 12-month Masters in Healthcare Leadership sponsored by the University of Warwick and IHED, and that'll be represented by David Brown here today, and Paul Flynn will represent the family. And I'm really excited and delighted to say that out of all the applicants this year who applied, the winner of this year's 2026 bursary is Hannah Kelly, Clinical Nurse Manager with VHI Hospital in the Home. And Hannah's going to join us on stage. Paul and David. So Hannah heard about this. So I rang Hannah last night and said, would you be available this morning to come into town from Wicklow? So it was a big shock. Do you want to stand closer to? Yeah. And, we're thrilled, Hannah, to give you this scholarship. It means an awful lot. And sorry, we'll have a photograph. We'll do this first, yeah. This is Paul and David. Yeah. Thanks. Thanks. So Hannah's agreed just to say a few words and tell us a little bit about her story. So we'd really love to hear it, Hannah.
So am I close enough?
Yeah.
Can you hear me? So yeah, I've worked with VHI Hospital in the Home for the past 16 years, and it's an amazing service, and I really love it. I feel like we're leaders in creating a new kind of healthcare system anyway. So to be able to gain more experience and skills with this is just amazing, and I'm so grateful. Like I really am. Thank you.
Yeah. And you're married and have...
Yeah, married, 3 children, a dog who I think I love more than anyone.
And you're living in Wicklow, isn't it?
Living in Wicklow, in Rathdown, yeah.
And you've been with the service from the very beginning?
It was operational for about 5 or 6 months before I joined, So I've seen it go from strength to strength, and it's amazing.
Yeah. Congratulations, Hannah. Yeah, we're all delighted. Thank you. Thank you. So our next panel is a panel building the backbone, the infrastructure that enables a modern healthcare system. And the panelists for this are Sharon Scannell, partner, head of healthcare at Grant Thornton, Daniel Baker, managing director and healthcare infrastructure lead at Grant Thornton, Katie Gosling, delivery strategy and improvement director of the new hospital program in the NHS, and Brian O'Connell, the national director, head of strategic health infrastructure and capital development at the HSE. And I'll let them talk and introduce themselves.
Thanks very much, Tom. Great to be here, everyone. Lovely to meet you all. As Tom mentioned, my name is Sharon Scanlon. I'm a partner in the head of healthcare at Grant Thornton, and this morning I'll be the moderator asking lots of really challenging questions and digging deep. No, I won't go that bad. I guess just to set the scene and feeding on from what Derek's just said as well, and I'm going to quote him now because he's talking about today's pressure, tomorrow's model of care. And what we want to get into this morning is we know there's significant investment happening across infrastructure in Ireland, probably more than we've ever seen before. But I guess it's not necessarily about building more, it's about building better, building faster. So we're going to delve in this morning with the panel that we have. We're going to look at what's Ireland doing now, how can we improve on where we're currently sitting, what can we learn from the NHS. So we're really lucky to have representatives here this morning from the UK. What can we learn from the UK, what can we bring to Ireland? And most importantly, I guess, speaking, and Brian will come to you a lot on this, what does the next couple of years look like for us? What does the next 10 years look like for Ireland in terms of infrastructure? So to kick off, Brian, I might come to you first, if that's okay. So as Ireland enters this significant period of investment and change from an infrastructure perspective, what do you see as the biggest opportunities to transform our infrastructure across the next 5 to 10 years?
Yeah, so we're fortunate enough to be in a position where we've, in the NDP, we've 9.25 billion being put into capital in the healthcare sector. Of that, and the infrastructure, traditional infrastructure, would be 7.25 billion into my side, and the remainder into the ICT end of it. So huge opportunities come from that. If you look at, so we're about to enter into, hopefully, subject to government approval in quarter 3, quarter 4, and the National Maternity Hospital. So delivering for women's health, bringing up that infrastructure in relation to the co-located National Maternity Hospital. Within that period, the Rotunda Hospital, hopefully if we can overcome the planning issues at the moment, there'll be a secondary investment there to a smaller scale. Again, you have the elective hospital. I know Derek touched on it earlier. The first phase on the surgical hubs coming on stream this year, and then enhancing next year as well. 2 elective hospitals, Cork and Galway, coming on stream. You have the acute bed expansion plan, over 3,000 beds coming over in that time period. Mental health, 7 priority sites been identified along with a programme in behind it. The disabilities, huge amount of investment in additionality across the disability sector. Community nursing units, a replacement programme that's coming to fruition now at the moment, nearly 85% complete. And then we're looking at the next programme for additionality over that. So at every element we're touching on and to try and develop that. So huge opportunities, very exciting time frame.
Brilliant. And I think it's really reassuring for us in the audience as well, just hearing even the list that you're calling out there of everything that's happening. And it's certainly a really busy time at the moment. I guess in terms of strengths that already exist, and I'll keep with you for a minute, Brian, like what can we build on now that's already there in terms of strengths from an infrastructure perspective within Ireland?
Yeah, so within being an informed client, so and this kind of gets lost, being an informed client both from our own perspective within my own department, but also within that collaboration within the service side. So that we are very connected. We're very lucky to be one entity rather than a number of trusts in the UK. So we're much better able to deliver closer to better informed, to make the most impactful investment. So we don't want to get lost into making wonderful bricks and mortar side of it. It has to have the greatest impact on the service delivery, the patient experience. The closer we are to our client, and the closer we are integrated with the service delivery arm, the better we can achieve. And I think we're within the HSE as one umbrella entity. We're much closer to that. So that's one element that we are. And just, I know it's mentioned surgical hubs, huge delivery. So we're trying to leverage and learn from that delivery, really successful delivery from announcement October 2022, 400 million programme will be delivered within that 4-year programme. So by any measure or metric, that's hugely successful to turn on. So we're trying to leverage that. So we've shown form, if you like. So.
Incredible. And I guess thinking about showing form, Katie, over to you. So you've been working in the new hospital programme for over 6 years now in the NHS. We're delighted to have you here. We always love to learn from the international perspective. I guess the new hospital programme has made massive strides over the last couple of years. What have been the big areas or the most positive impact in terms of pace, consistency? What have you been doing, again, that we could learn from here in Ireland?
Yeah, thank you for having me. It's great to be here. I think, firstly, the new hospital programme is a transformational programme at the heart of it. And the first few years were spent sort of really looking at how we stand up a national programme right across the NHS to deliver the acute hospitals. Over the last year or two, we've really made some strides. So we had the new hospital programme review back in 2025, and that gave us the funding. And that was a pivotal point for us. So that was 15 billion over 5 years. So the investment was pivotal. That also gave us an opportunity to move the schemes into waves, so a really deliverable programme. what we've also done in that time is develop Hospital 2.0, which is a whole system. And also we've brought on board our health delivery partner to support us in there. And this summer we've stood up the Hospital 2.0 Alliance, which is groundbreaking, because about 2 years ago we had about 4 large contractors that would want to build hospitals in the UK, and now we've got 10 all aligned with the schemes coming through.
Amazing. Will you tell us a little bit more about Hospital 2.0? Because I'm conscious for the audience, if you've learned, we hear quite a lot about this. What exactly does it entail?
So it's a full system. So it's it has design at its heart and standardisation, and so we've created what is a sort of kit of parts of standard designs for either single bedrooms or different elements within the hospital. But it's not really just about the design and the building. It's about how it operates. It's about the digital layer on it. It's about the workforce layer on it. And so the system has designs plus standard service operating models, target operating models, digital layers, and also we've been developing like a life cycle to make clarity, because I think the thing we found is actually bringing clarity and consistency and standardization is the key to doing things quicker.
Brilliant. Really interesting. I think we'll delve a little bit more in a minute as to, maybe I'll come back to you in a few minutes, Brian, after I chat to Dan, just on what we can take away from that or what lessons we can learn from the NHS model. Dan, you've been working across Wave 1, Wave 2 cohorts in the new hospital programme as well since 2020, if I'm right. Talk to me from a programme management perspective. What have you learned? What's worked? What hasn't worked, particularly for the audience here again, as to what we can take away from that?
Yeah, thanks, Sharon. So I think if we look right back to sort of 2020 at the start of the programme, and Katie's described some of the transition the programme itself has been through, there were sort of up to potentially 30 hospitals that all thought they were going to be part of this journey. So they set up with best intentions their own governance models. They integrated those with their kind of decision-making pathways within regions, within organisations. What became very challenging, I think, then for the central programme was how do you sort of keep all of those individual schemes motivated, infused, engaged, whilst also trying to overlay that standardisation, which Katie's referred to, which really has been an innovative component of the central programme. So I think what we've learned over the years and what we've seen work really well is where you can standardise those decision-making models, those governance models, and the engagement between the individual schemes and the central programme itself. From a programmatic perspective, that's where you start to get a lot of the benefits. I think the other piece as well is getting the investment in early into your central capability to do that. So standing up the right teams with the right playbook, the right methodologies. You know, if we were starting the new hospital programme from today with all the things Katie's just mentioned, those first 5, 6, 7, 8, 9 schemes would fly through in a way which the early schemes didn't back in the early days. So yeah, invest in the capability up front, standardise the approach, and overlay the governance between the central programmes and the individual schemes.
And those would be your key takeaways probably to us within the Irish system.
Correct, yeah, and I think, as Brian's touched on, I think you've got the benefit of being one integrated system from the start, which should potentially alleviate some of those barriers that we saw with the early schemes.
Brilliant. Brian, I might bring you back in terms of, I guess, listening to Katie, listening to Dan. You obviously deal with people in the new hospital programme probably quite regularly anyway. What's your sense of what we can adapt or take from learnings from the UK to bring to Ireland?
Yeah, and like there's no silver bullet, I wish there was. So that's the element. So what we're trying to develop at the moment is the suite of standards. So we've engaged both with looking to our UK colleagues, but also to others out in the States as well, just to see what other has worked well. So that standardization and that continual improvement. So if you deliver once, we're also in a slightly different backdrop, is that we're, rather than a full hospital replacement program, we're into providing additionality, additional capacity. So it's war blocks versus replacement of hospitals, so slightly different market as well. But the standardization, the centralized, that super user group, that central kind of expertise that's coming. So it's not different, special and different in every different area, that there is a war block is a war block, and it's consistency, and you're getting that minimum viable product. So every time you go to see, well, is there anything we can drive efficiency on from the bricks and mortar side, but also from the efficiency from the operational side, and just that element. Is there elements that even the numbers of beds, is there elements that will drive greater efficiency from the staffing ratios, and elements like that, and that national group that, like we've done in the elective programme, is that there's an overarching national group, but then there's the regional input. So both are married together, and that's critical, that there's no fraction between the two either.
Brilliant. And I think as we look at it kind of in the broader context, so we can have all the blueprints, as you say, there's no silver bullet. The key piece probably is with any of these infrastructure changes, bills, is the amount of stakeholders involved in any of this. And I guess, Katie, I might come back to you again from the UK perspective of what's helped build momentum in the UK, I guess, in terms of aligning stakeholders, maybe bring the patient into this as well as at the centre of it, and give some of your perspectives. And I know you're very passionate about governance in particular, so maybe if you could touch on that for the audience as well.
Yeah, and I think that's been a bit of a journey for us, if I'm honest, because it's quite difficult to stand up a national programme in what is quite an established regime with trusts, with sovereignty, and also within an assurance space. So I think for us, it's been key about stakeholders, but part of that is about really people becoming confident that the national programme can help, and us really engaging across the board. So all the designs and the models and everything have been landed with the Royal Colleges of Physicians. We have engaged right across from patients through to communities, because having a new hospital is a great thing, but it also can have a massive impact. The 10-year plan is interplaying with what we do and how we seek to define scope in that. So yes, it's been quite a journey. I think the biggest thing for me in this space is mapping out the stakeholders and understanding exactly what they need and their perspective on things, and making sure that patient voice is at the centre.
I think that's key, and Dan, I might come to you on that as well. Putting the patient at the centre. What have you seen since 2020 in this space? Like, what works? How are you designing models that bring the patient into the middle of this?
So I think there's a few things that we've touched on already. So Katie mentioned Hospital 2.0. People refer to it as a reference design, but it's so much more than that. It's a system in which these facilities can be operated and built. The thing that I always say, and that we see across some of the really well-run schemes, is that the building is a wrapper, right, for excellent healthcare. And these buildings will be built in 5, 10, 15 years' time. They won't be built for the healthcare that we know today. They need to be built for the future, so they need to be adaptable, they need to be flexible, they need to be built with future models of care in mind. And that's challenging because we don't know exactly what those models of care are going to look like. So the way I think the new hospital programme and some of the more progressive schemes have been successful in doing that is bringing the patient voice to the centre, leveraging digital enablers, looking at technologies that we may not use today, but we know other parts of the health system globally are using, and really focusing in on what the patient will require in the future, and then building a system around that for which the building ultimately becomes the wrapper.
Brilliant. I guess, Brian, you've talked quite early on in your first answer about all the different elements that are potentially opening surgical hubs, etc. Talk to me about what success looks like for a new healthcare facility opening. What are the key components from day one to get right?
Yeah, so from my perspective, so when we go and visit a location, and we were down in Cork a few weeks ago in relation to what
Cork is critical to the journey.
Cork for the
all
new
investment should be in Cork.
yeah, but the new surgical hub. So we would have walked the surgical hub from the journey of the patient. So we would have been there to see, well, where the efficiencies arrive, and where do you come in, where do you go into the theatres, where do you come out, where do you recovery bay 1, recovery bay 2. So what's the journey, what's that experience? So that's critical. The other element is that every time we build something and have a programme of investment, it's a transformational programme. so that it's not just lift and shift and it's not just doing it the way we always have done it, that we're making sure that we're looking at every aspect of how we do it, and can the physical infrastructure be a big enabler for a change program as well from the service delivery side. And that we right size them. So again, we can go always and your scope and your scope creep, so that we right size it, that it's not too big, but there's future proofed, but it likewise that it's not too small, and then we don't get the full advantage of it. It's very good, very hard to land that. And that's sort of it, so that we drive the clinical efficiency and that service transformation and the patient journey is really, really important.
Brilliant. I don't know, Katie or Dan, if you want to add to that again, in the concept of a new hospital opening, any key elements you'd be focused on and things you're thinking about, or workforce planning, service design? What do you see in the UK?
Yeah, I think the scope's been a really interesting one for us, and we've developed our own demand and capacity modelling. We've also developed a cost standard model, and that just brings confidence because you're rolling things through in a standard and you're only dealing with the difference in that. So I think that's key in that area around driving that confidence.
Yeah, and I think the final thing to add is that transformative element. So again, building things for the future, you build your kind of operationalization and your opening metrics, if you like, in from day one. So you understand right from the beginning of the journey what the facility is going to look like, how it's going to operate, but also you build in your assumptions around your left shift and your transformation and what future models are going to look like in terms of care in the community and what types of patients, therefore, you need to see in your hospital versus the patients that can be treated elsewhere.
Yeah. And I guess a follow on, and it's open to any of you on the panel, in terms of investing in the right places and I guess giving confidence back to the public, like what's our way that we can do that to ensure that we're investing adequately in the right areas and making the right decisions when infrastructure is something that's permanent? How do we ensure that the public has that confidence that we're doing the right thing and investing in the right spaces, I guess, in Ireland and across the UK?
Well, I'll take that. So that is the data-informed decisions, so that you have your data modelling done, you have your projections and solid projections, that you do your stress testing on your assumptions that you're baking into the model, and those sort of elements, that you're able to demonstrate that this is, again, going back to Sláintecare, that it's delivering care close to the community, it's delivering care in the appropriate setting. And that we really have to test and challenge those assumptions that when we're making those models.
Perfect. And Brian, I might stay with you for a second. I've been given the 3-minute warning. Looking ahead to 2035, let's look broader. What will the Irish healthcare landscape look like from an infrastructure perspective?
Yeah, well, if you look at the programs that are alluded to initially, so hopefully we'll have the surgical hubs absolutely humming. We'll have the elective hospitals in Cork and Galway, and the one in Dublin's, the two in Dublin then delivered as well. National Maternity Hospital will have, for women's health, a huge advantage for women's health, and it's far more than just a maternity hospital. Have that up and running and absolutely operational. I would like to think we'll be on the second phase of an acute bed expansion plan, that phase 1 will be completely delivered. Your mental health, that all your 7 acute mental health for the most vulnerable, that there is a significant investment in acute mental health. The community, the programme that we're currently moving on to our next additional capacity on our CNU programme, so for our older person services, primary care, ECC, so our enhanced community care as well as our primary care. And our primary care strategy has been very successfully delivered over the last 10 to 15 years. So it's to making sure that whatever gaps are there, or any further enhancements from the primary care side, to make sure again that shift left, to make sure we're dealing it in the community and we're maximising it and maximising that utilisation.
Absolutely. I think it's really reassuring to me, to the audience, even listening to that and knowing what's coming. And I guess I might close off. Katie, Dan, I'll come to both of you, and then I might revert back to you for the final say, Brian. In terms of that trajectory and everything that Brian's mapped out, what's your one takeaway you'd say to us as to what you've learned over the last 6, 7, 8 years in the NHS and the programs that you're doing? What's the one thing you'd say to us as we embark on this broader journey?
So I think, for me, change is hard, isn't it? And therefore, I think we need to understand that it's a team sport, and actually sharing lessons learned, communicating, looking and master planning sites effectively, looking at operational readiness early, and reducing variation are the key to successfully making this work, I think.
Dan?
Yeah, I'd say to build on that, two things for me. One, I've mentioned before the building being the wrapper, align these designs around your existing strategies. So have a strong, robust clinical strategy, a robust workforce strategy, and then build around that. And then the final thing to say is work with people that have done this before. So genuinely look to people that have been through the challenges, have experienced the pain points, and bring them into your team to help you shortcut some of those issues, because we all like to think that all of our facilities and all of our ecosystems are unique and different. In reality, they're not. We're all facing the same challenges. We're all here for the same purpose, and bring that capability together.
Brilliant. And Brian, will close off with you. There's no silver bullet, but if there was one thing, what's that kind of key piece that you think will be critical to the success of the journey you've mapped out for the next 10 years?
Yeah, so multiple models of delivery. So I think that if you have one single delivery, you're pigeonholing yourself a little bit. So we're trying to expand and engage with the market to see, is there other opportunities? Is there other ways of doing things? Like if you even look at surgical hubs, we've delivered it in 4 different models. So that then you can choose and tailor your solution to best fit the problem that at hand. So that we're trying to ever increase or expand our number of solutions rather than being restricted and I think has served us well today, so to do a mixed mode of delivery solutions.
Yeah, really powerful. And I think the key takeaway I took is loads of investment for Cork. It's critical.
That's what we heard.
Brilliant. I'm being told time is up, so thanks everyone for listening, and thanks so much to the panel, and in particular to our guests who've joined us from the UK. I think a really good morning. Thanks everyone.
Thanks very much. Just to be quite clear now, all the investment isn't going to Cork. There's some shout out there from Derek and the North Kildare Brigade. There's certainly plans afield there. Brian, very impressed with how you told us all about the great work that's been done in the infrastructure side. I certainly, in the primary care side, have seen that over the last 15 years. We've got very good at building health infrastructure, and I'm very excited to hear you talk about the ambitious plans for the future, and I think it'll deliver for Irish patients. And thanks to everybody else who participated in that panel, Sharon. Our next person I'd like to call to the stage is Deirdre Collins. Deirdre Collins is presently chair of the ICGP, and if you want to find a good example of strong, empathic female leadership, Deirdre is certainly one of those kind doctors who's done a great job leading the Irish College of General Practitioners. I have to say that she was my boss at one point in Beaumont Hospital about 25 years ago. So I'd welcome Deirdre to the stage to introduce the panel on women's health. Thanks.
Only a minute. Good morning, everybody. I think I'm going to unfortunately throw Tom under a bus and say that it's 25 years plus VAT. So good morning, everyone. Thank you for that kind introduction from my colleague. Good morning. It's a pleasure to be here to support the Future Health Summit and the work being done by David Neville and his team, and in particular my long-standing colleague, Dr. Tom O'Callaghan, who is many, many things, but also a very, very kind and empathic general practitioner. As a GP, it is great to be part of this workshop in particular, because the care of women, from the pregnant woman through her pregnancy journey, through the care of that infant, through childhood, to the teenagers and young women seeking contraceptive and fertility care, all the way through to women in perimenopause and menopause, and of course, most importantly, our healthy and vibrant population of older women who have great expectations for their health in older age. And that is the core of general practice work. And what we bring to it, we know, is continuity and whole person care. So this morning's workshop, it's so important for, as a general practitioner, to be here for this. Having had the opportunity to work with the speakers in preparing this morning's workshop, it is a truly inspiring space to be in and to hear what they are going to talk to us about, how healthcare for women has evolved over the last 10, 20 years, and how it will evolve over the future years to deliver hugely for Irish women. So I will start by welcoming our first speaker, who is Dr. Linda Keaveney. Linda is the Chief Clinical Officer for VHI. She brings over 25 years of international clinical and leadership experience, leading strategic healthcare programs and playing a key role in advancing digital health and modern care delivery. This includes the rollout of VHI's electronic medical records. Her work focuses on improving patient outcomes through innovation, quality and education, and I know you're going to be very interested in what she has to say. So join me in welcoming Linda to the stage. Thank you.
Morning, everybody. Thanks very much, Deirdre, for the introduction. And I'm delighted to be here this morning to talk about something that I think, as a GP, I kind of care for deeply. When I was thinking about this, I wanted to kind of think, so I suppose when you think about women's health, to talk about where we are and where we're going to, I think it is important to understand where we've come from. And that's why I kind of want to kind of have a little bit of a look back before we look forward. So really about understanding women's health through time. Now, if I can get the clicker to work, I'll be very happy. Yeah, perfect. So basically, I suppose what I want to do is have a look at kind of an overview of women's health evolution socially and scientifically, because there has been, I suppose, a historical marginalisation of women and their inclusion in policy and research. So if you look at it, kind of, I suppose, in Ireland, you know, historically, the Catholic Church had a huge influence on policy, women's health and healthcare in general. In UK, there was kind of this Victorian kind of era where medicine and kind of social repression was there. There was this kind of sense of women, this kind of hysterical women and kind of the you know, kind of this control over women. And there has been over the, I suppose, historically, this kind of religion and patriarchy that has had a huge influence on where women's health has come from in the past. And I just put this one in as something that's a little bit kind of interesting when I was doing my research. So pioneer Irish-born surgeon Dr. James Barry, who was actually born a female, Margaret Bulkley, I think, who lived as a man, basically wanted to be a surgeon, always did, knew that wasn't going to be able to be a surgeon, and so lived as a man, trained as a doctor, became a surgeon, did the first caesarean section in the British Empire, which was when she was working as a surgeon in the British Army. And only after she passed away did it come to light that it was a female all the time. And I just think, imagine that's where we've come from. Whereas a woman, she had to live as a man to do what she wanted to do, whereas now we have lots and lots of eminent female surgeons and doctors and other careers. So I suppose just to kind of move forward kind of in the early 20th century, that kind of shift from kind of religious to state kind of control of women's health and healthcare in general. So I suppose in that kind of, that transition happened, the state in the early 20th century, which to a large extent have kind of, I suppose, kind of put out kind of the management of healthcare a lot to the religion, to the Catholic Church. A lot of hospitals and so on were kind of ran by religious institutions. And that definitely had a big influence because there was religious influence then on legislation and things like, you know what I mean, the mother and baby homes, the Magdalene laundries, and lots of things, I suppose, that when we look back, maybe, you know, are things we don't feel proud of as a country, but that's where we've come from, and it's important to remember that as we look forward. I think a really uplifting side then would be that story around Dr. Noel Brown. I remember years ago my father talking to me about Dr. Noel Brown and wanting me to read the book, and it was probably when I was a teenager and I was rolling my eyes and not understanding. And I stand here today and I think, God, my father would be laughing if he saw me here talking about Noel Brown. Noel Brown, I'm sure many of you are familiar with, was an Irish doctor and politician, grew up in reasonably kind of not affluent circumstances and became a real proponent. He put forward this mother and baby scheme back in 1950. He actually wasn't, he's synonymous with that program, but he actually wasn't successful in getting it through when he was in politics. It was back, he had resigned actually, and in 1953, a kind of adapted version of it was put through. And I think that was kind of a real key point in women's health in Ireland when that was happened, that kind of acknowledgement that, you know what I mean, we needed to do better for women and children. So if you move forward a little bit, I suppose, to the 1960s to the 1980s, I'd love to say I don't remember it, but I do, unfortunately, where feminist activism kind of really started to kind of, I suppose, challenge our ideas about reproductive control. You know, there was, you know, the pill became available in the 1960s, and that access to contraception and things like abortion became kind of, you know, available. And that's important, I suppose. That was around the time in the 1970s when I suppose a significant number of women wanted to enter the workforce. So the availability of contraception wasn't just about that. There was the social impact then of this freedom for women to be able to manage their fertility, be able to kind of enter, make decisions around education, not necessarily have to get married straight away, enter the workforce. And so there was a huge societal impact as well as, I suppose, you know what I mean, the clinical or healthcare impact of that. So then I suppose where kind of that late 20th century to today, kind of where we're at, and I suppose the challenge is now, like, we've come to where we are and there's so much progress that's been made. The challenges probably now are just basically to make sure that we consider that all the time, that inclusion, that understanding, that including, I suppose, gender and sex into kind of policy, how we shape things is really important, and to make sure we don't forget it. And I think as well, you know, whilst we've definitely see a lot of advances in kind of the reproductive health, menopause, mental health, it's to make sure that we also, you know, as Deirdre referenced, kind of thinking forward, you know, so, you know, focus on prevention, holistic women's health models, understanding the woman as a whole, as opposed to kind of that fragmented piece of, you know, contraception, menopause, all about hormones. It's important, but the holistic view is really important. And one, I suppose, when you think, why is that important? Well, it's really important because it's absolutely the right thing to do. I was driving up this morning, I was thinking, I have a 15-year-old daughter who is very articulate at telling me all about what I need to do better and what we as society need to do better, or adults in society. So it's absolutely the right thing to do. But it makes sound economic, and I suppose when you're looking at, you know, the challenges that face healthcare in terms of, you know, the people living longer, you know, the rising cost of healthcare and so on, and you know, just the capacity, treating women holistically, understanding women's health kind of in that holistic sense. There's a real kind of advantage to that, because it means that, you know, at the minute, I suppose what you'd say is women are living longer, but women live longer sicker, so live longer with chronic disease. If we can really address that kind of holistically women's health, there's real opportunities in terms of prevention, you know, the kind of sustainability of our healthcare ecosystem and that ability to use the resources that we have in a better way. So I suppose just when you think about that, what are the kind of areas that we might consider? And I suppose a huge one really has been the scientific neglect to date. So really, when we think about that, it's that kind of thing where hugely up until now, a lot of kind of research has been focused on, you know, a 70-kilo white male, I suppose, was the traditional kind of thing, but definitely very male. So there would be historically a lot more studies that are entirely focused on males rather than studies that are entirely focused on women. And there's been a real deliberate and a really successful actually change in that now, where, and it's across the whole sphere. So it's making sure that, you know, when we're doing research studies that, you know, if it's appropriate that women are included in equal measure, but also things like that the people who do the studies, that there's a gender balance in terms of researchers, that the academic institutions demonstrate a gender balance, and you can really start to see the benefits of that nowadays coming to life. So I suppose then, why does kind of, you know, sex and gender matter in medicine? Well, we know that there's lots of things. So sex affects biology, you know, it affects how medications work, that kind of thing. But also gender affects lived experience. So, you know, if you're ignoring kind of sex differences, it's both kind of from a clinical or a kind of perspective, it's putting women at risk. But we also know that, like, you know, say certain things, women's experience of pain can be different in areas where clinical symptoms aren't clearly understood. There has been that kind of traditional kind of approach where, you know what I mean, if there's the kind of those cultural norms where we kind of think, oh, it's, you know what I mean, just imagined, or it's just kind of, you know, that vaguely histrionic thing. And those things impact the ability of women to be diagnosed. And, you know, we'd see that that's coming to light with things like endometriosis and pain and things like that. So it really does affect the treatment of women. and just even from a purely kind of practical sense, designed for men often disadvantages women. And he put that photo of the policewoman there because when I was looking at stuff, there's in the UK there had been 2 policewomen. Well, there was one policewoman who she was entering a house with a battering ram, and she'd taken off her vest because it didn't fit her. She wasn't able to use the battering ram, and she was stabbed and died because she didn't have the right protective gear. And when there was a kind of look back on that, there was a number of other policewomen who had said the same thing, and it turned out that there was one policewoman who had a breast reduction so that she could wear her personal protective gear. And when you think about things like that, you just think like they seem so basic, but you know what I mean, they have such a huge impact. And having that kind of recognition now allows us to be much more mindful about those things going forward. So I suppose women's health, it's not a single moment, you know what I mean? There is a lifespan, you know, and it spans from kind of puberty, fertility, menopause, aging well. And so when we look at this, we absolutely need to, I suppose, make sure that we're addressing all of the different phases and doing that in a holistic way. So some of the really positive things that have been, there is, you know, the state, the Department of Health has a Women's Health Action Plan, a Women's Health Task Force. There's been huge resources put into that in areas like contraception, menopause, endometriosis. So there's a lot of work already being done, lots more to do. I've mentioned kind of about the policy forum around sex and gender inclusion, and that's both at an Irish level with the Health Research Board, but also obviously with the EU policy and the Women's Health Action Plan, which has a specific section in it about growing the evidence and making sure that research is inclusive of women's health and women's experience. So I suppose just to touch on what we're doing in VHI for women's health. So women's health in VHI is a strategic priority for us. So we have approximately 1.2 million members. About 62% of our membership are female. So there, you know, it's a big, important membership for us. Our own workforce, we have approximately 2,000 people who work for VHI, and about 67% of them are female. So both kind of, I suppose, from a membership and a colleague perspective, women and women's health are really important. So some of the things that we're looking at are kind of education, and I think that education, like both at kind of undergraduate and postgraduate level, is really important to start kind of understanding and getting people to think about gender and sex in kind of decision making, how you approach issues, how you understand how disease presents. So we're definitely looking at that both internally within our own kind of service provision and what we do when we're kind of doing educational sessions outside of VHI. We do have a dedicated women's health clinic that it is kind of that aiming to address a female holistically, you know what I mean? So not just kind of around gender, you know, kind of hormonal related issues, but the whole woman in general addressed with a multidisciplinary team. We have a midwife support service that tries to support females as they go through pregnancy and postpartum. And then we have done some research in kind of women's health in the workplace, and there's really interesting insights that have come through from that, like both with kind of our corporate members, but within our own colleagues as well, and the different challenges. And there's a huge, I suppose, advantage to kind of having an awareness of how you support women better in the workplace, because it kind of, suppose, supports women to be able to stay longer in the workplace or be able to be in the workplace where previously they may have had to kind of make a different decision. And I suppose then, you know what I mean, in conclusion, like what I suppose, you know, when you look back to where we are now, there's a huge amount of work has already been done. There's a huge amount of kind of change has already happened, and there's lots of opportunity for us. And I think it really is about a really inclusive model and us all working together for that. Tom mentioned in his opening note about making sure that patients are kind of, you know, front and center of what we do today. And I think that's so important when you think about women's health, that kind of making sure that how, you know, at every step, you know what I mean, in what we're doing, how we can include women's voices, you know, in terms of evidence and reform, because for sure they can tell us how we can do things better and their lived experience, and moving away from that where that wasn't traditionally not fully recognized. I think it's really important that we reframe women's health and have it not just about reproduction, but also about kind of the whole kind of women's health. And I actually meant to mention it earlier, like there are things that I've seen that are really good for that. So I'm from the west of Ireland, so I think all the resources should be going to the west of Ireland. But anyway, I'm from the west of Ireland. CREE is the West of Ireland Heart Foundation. I'm sure a lot of you are familiar with it. They've got a really good programme that looks specifically at women in terms of heart disease. Heart disease is the leading cause of death for females in Ireland, and it can be traditionally under-recognised in women, and you know what I mean, not necessarily the presenting symptoms really well understood. So they have, and I'd encourage any of you to Google it and look it up, because I was really taken by it when I saw it presented. This Her Final Moments. It's I suppose a program that they had where they looked at women. You know, women will traditionally kind of try and sort out their own issues themselves. So when women were having these symptoms and they didn't understand what it was, say it wasn't necessarily chest pain, they were Googling it, and they managed to kind of get Google searches of women who actually had heart attacks, and search, like, what were the search terms that they used, and they put them together so that when people put in those search terms into Google, that it would come up, you know what I mean, to suggest to them about heart disease. And I just thought, God, imagine, you know what I mean, it's a really clever thing to do, but it just highlights, you know what I mean, how different things can be, you know what I mean, and how important it is to have the correct information. And then I think the last thing there is, you know, that absolutely we need to make sure that we're integrating sex and gender in research and into clinical practice. And I think it kind of goes nicely with the speakers who are coming behind me. So we have somebody from the Irish College of General Practitioners. I'm a GP myself. They've got some really excellent education programs for GPs, and a huge amount of work done through the college for women's health. So, you know, and again, the femtech industry would have really brought things forward in a women's health space as well. I think they really have been kind of, you know, advancing very quickly, you know what I mean, our data, the available data that's available to us through things like wearables. I think they also have been able to kind of, some of the areas that maybe have got kind of not spoken about in the past, femtech are really addressing those gapped areas. So I think integrating all of that together, you know, will really support us in moving forward in the women's health space. And I think I really like this quote, that medicine changes when women refuse to be invisible. And I think I challenge us all to say that we can all champion evidence equity in demanding that data reflects sex and gender in the population. We can all, you know, raise the standard of care through education and advocacy. We can, you know, we can all, I can't even read it now, value women's voices by recognising lived experience as data, and I think that's so important. And we can lead with empathy and insight. And I think we can all mentor and multiply the impact. You know what I mean? Lots of you here will have mothers, sisters, daughters. So I think, you know what I mean, there's lots of opportunity outside of, you know what I mean, the strictly clinical spends. Thanks very much.
Thank you very much, Linda, and thank you for the kind words about the college. Over the course of 6 years, as I always say, in 2021, when Joe Duffy invented the menopause, which is incorrect, but I suppose from a college perspective, the drive to upskill and increase our education came first of all from patients, through the GPs and into the college for that need. And it's very important for us to recognise the great support we've had from the HSE and the Department of Health in providing that education. So it's, again, a great pleasure to welcome another colleague, Dr. Laura Cullen, who's Director of Women's Health at the Irish College of GPs. And she's also a working GP, probably going back to surgery this afternoon, bringing frontline experience to her role. She provides a national leadership on advancing women's care, healthcare in primary care, championing access to high-quality, evidence-based, patient-centred care across all stages of life. And she is a passionate advocate for inclusive and integrated care. So thank you very much, Laura.
Hi there, everybody. So, as Deirdre said, my name is Laura Cullen. I'm a GP with a special interest in women's health, and I'm also the director of the Irish College of Women's Health for the Irish College of GPs. So just a big picture background for general practice in Ireland. So general practice in Ireland does about 29 million consultations per year. It's a huge number for about 4,500 GPs and about 900 to 1,000 GP practice nurses. And that basically amounts to about 100,000 consultations Monday to Friday of most of the weeks of the year. I suppose to expand upon that a little bit, just to say that all consultations in general practice are becoming increasingly complex, and women's health in that regard is no different. So I'm going to bring it back to the patient, and we've been talking about doing that because I can talk to you about high-level stats, and I'm going to lose half of you within minutes. Helena is not a real patient. She's an amalgamation of several patients that have come into me over the last couple of months. But some of the things that Helena is going to say, I have heard, unfortunately. And I'm delighted because Helena has been booked in by the medical receptionist as a contraception consult just before lunch. And I'm thinking, God, this will be a nice quick one. Helena's a great girl. She'll understand exactly what I'm going to say to her, and I'll be able to advise her and keep her safe, and I might even get lunch today. And a spoiler alert, unfortunately, I don't get lunch. It doesn't go according to plan. So Helena has started college, and she has a new boyfriend, and she wants to talk about contraception. She's worried that hormonal contraception is not for her because, unfortunately, I have heard these words, it will make her fat, more spotty, and less attractive to men, which she's read online. And I have to say that was like a dart through my feminist heart. Had to try and stay calm at that point and not react. Helena has irregular periods and a very strong family history of polycystic ovarian syndrome, which has now been, for some of you might be aware, it's now been renamed polyendocrine metabolic ovarian syndrome to reflect the lifelong health impacts that that condition can have on some of the women who suffer from it. I know Helena a very long time. I know her probably since she was about 12. I treat some of Helena's sisters. I know that her elder sister is struggling to conceive at the moment, and that's probably related to her polycystic or PMOS syndrome. And I also know that her mother, who's in her 50s, has recently been diagnosed with diabetes, and that's most likely related, again, to this condition that runs in the family. So she'd like to use the app that a couple of her friends are using to track their cycles, and maybe to help her with her reproductive care and contraception, but she's not sure, and she's right to ask me that question because her cycles aren't regular, and maybe the app might struggle a little bit with that. Her acne's deteriorated, and some of the hair at the front of her head is starting to thin a bit, and I'm a little bit worried about that because that does suggest that Helena might be going down this track of PMOS. And she's wondering, does she need a scan to confirm her diagnosis? And maybe to check also for endometriosis, because a friend of hers has recently been diagnosed with that and she doesn't want to get that. But I'm happy to say that Helena has never suffered with any pain related to her periods or otherwise. So trust is everything in general practice. It's everything. And just to come back to Derek Tierney's point about trust, the care that we provided has always been personalised, always. As I said, I know Helena, I know her a long time, and I know her whole family. And that trust is generated over the life course that Linda referred to there of Helena and her family. But it's also generated over multiple generations. And general practice is the real sink of that very, very valuable trust and information and data. Helena trusts me with her information, and despite the fact that I know her family, she's happy to give me that information because she knows that's not going to go anywhere, and I'm really proud of that fact. And I'm also really proud that she's willing to come to me for my opinion because she's constantly being bombarded with information 24/7 on her phone that maybe undermines some of the advice that I'm going to give her. So I'm going to come to the idea of data being trust, and I've already alluded to that Helena trusts me with her information, and she trusts that I'm going to keep that safe. But there's another piece of data and trust that we don't often talk about as medical practitioners, and that is, why do we trust ourselves with the information and the advice that we're giving to patients? And the reason that we trust ourselves is that increasingly the advice that we give at the coalface has to be from a high quality place. And that comes from the top of the medical evidence hierarchy. And for those of you who aren't familiar with it, but I'm sure many of you are, that would mean from research that comes from publications like systematic reviews and meta-analysis. And those are the things which increasingly inform the international guidelines that GPs follow and the national updates that we in the college produce. And it's vital that we can stand over the advice that we hand over to somebody like Helena. So robust investigation allows for data integrity, and it allows me to trust what I'm saying to Helena, and therefore for her to trust me. So back to Helena. She said she'd like to use the app to track her cycles and maybe as a form of contraception. And I'm like, oh God. When is she going to be back into me? The alarms are going off in my head there. Many apps on the market, like for tracking cycles, are free, as many of you will know, are free at the point of entry for patients. And then obviously they can do a paid subscription to increase the services they receive from the app. But why are they free? Okay, and I'm going to come back to that in a minute. So very recently, this image here is from the current issue of a very high-impact journal called Contraception. And it's one of the journals that I just keep an eye on because of the nature of my work. But this particular journal has a very impressive editorial board. And in their editorial piece from the issue, they conclude that femtech currently in the sexual and reproductive health landscape appears to be a high-stakes experiment happening in real time with inadequate safeguards. Now that's really stark. And I'd like to think I'm being brave saying something like that in this room. But this is something that is current opinion of a very, very well-respected editorial board of a high-impact journal, okay? And that worries somebody like me. It does. It does worry somebody like me. So when does data not equal trust? So I'm going to come back to Helena and her idea of using the app. And I want you to consider the notion of women's intimate health data, okay? So unfortunately, there's evidence to show that some of the apps that Helena may consider using, that data is often sold on to allow for that app to make income, to allow for its development and for its maintenance, okay? Also, there's several pieces of evidence to show that that data sometimes, which is taken from users in this part of the world, is processed in jurisdictions whereby the law in relation to how that data is used is not as robust as in this jurisdiction. And there's also significant evidence discussed in the issue of that journal that shows that, that even if permissions are given, that you require a college-level education to understand what the implications of those permissions are, should you give them. And also that even if you don't give full permission, sometimes the data is processed in other jurisdictions or in places that you don't understand the implications of. So it kind of brings to mind the old adage, if you're not paying for something, then you're the product. And I'm afraid my children are sick of hearing that one. So I don't want you to think that general practice is anti-technology. It isn't. I started using an AI scribe the other day, and I am a convert, okay? But, and I don't also want you to think that general practice is anti the idea of women being empowered about their own bodies. I love young women like Helena coming into me. I love women in their 50s coming into me, wanting to hear about the gel as opposed to the patch form of HRT. We want women to advocate for themselves. In fact, 52% of GPs are now female, and that number goes up to over 60% between the ages of 35 and 60. Not only are we GPs and doctors and clinicians, but we're also patients, and we also have needs ourselves. So we need to advocate for ourselves too, and we want our patients to advocate for themselves. But GPs are trained to be staunch advocates for their patients and protectors of them and protectors of their healthcare needs. So What can we do in terms of safeguards around women's intimate data? So that idea of women's intimate health data, that's what I'm talking about, and making sure that it stays safe. Can we bake into app development intimate privacy by design? Now, these are not my ideas, okay? Total open disclosure. These are some ideas that are being discussed in the literature at the moment. There may be an encryption expert in the audience today, and I'd love to hear from you if there is. But we encrypt financial data. Why can't we encrypt women's intimate health data? The regulators need to catch up. We need you to catch up. Please catch up. There's a very interesting legal article in the issue of that journal I spoke about GDPR being the gold standard internationally, and it's not sufficient to regulate how women's data is currently being processed. And more worryingly so, in the Swiss context, where not only do they have to meet GDPR standards for the European Union, they also have to meet their own legal standards. And there's plenty of evidence to show in that context that there's still information getting into the wrong hands. How about public resourcing for app and technology development so that the income for these apps is not dependent on the data sales? And then this last piece, I would love to say it came from me, but I have very recently worked in a part of the city where a very good friend of mine, Dr. Breed Shanahan, works. She is a GP who serves the most disadvantaged part of, one of the most disadvantaged parts of our country. And she speaks very eloquently about the idea of equity in femtech development. Who are we developing it for? Are we developing it for privileged white women like me? We need to think about equity. And equity is absolutely essential if this is to be of use for all women, not just women like me. And to come back, so what about the, I'm going to come off on a little tangent now. What about the power of general practice data? Okay, so this is total tangent stuff. But general practice has been computerized now for more than 26 years in a lot of cases. And just go back to that figure I mentioned at the very start, 29 million consultations per year. We have computerized electronic data in general practice for 29 million consultations per year on average for the last 26 years. This is a question we need to ask ourselves, but maybe some of you in the room will have some ideas around it. What can we do to harness that data for the benefit of women in Ireland today? And just also to conclude, again, on Linda's image, I think this image says 1,000 words, don't you? I really think it does. It tells us how far we've come. The battles we have won in relation to control of women and their health have been hard fought, and Linda explained that much more eloquently than I'm ever going to explain. But I want us to really consider that protecting those hard-won gains is absolutely paramount. And I'll also leave you with this idea. There's an irony in handing over the control of women's data in the name of the freedom of control of our cycles. Thank you.
Thank you, Laura. And as you can all hear, the passion that Laura brings to her specific area of practice is so evident. There used to be a phrase in general practice that the GPs were gatekeepers to healthcare. We don't like to use that word anymore, but we have a word, a different one, which is that we shepherd people through their lives through healthcare. And I think Laura just brings that to life so well this morning for all of us. So moving on, another speaker this morning is Dr. Tanya Mulcahy, who's Director of the Health Innovation Hub in Ireland. She leads a national initiative supporting healthcare innovation from concept to the adoption of it. With over 25 years' experience across product development, research, pharma and startups, she champions health tech development, particularly in women's health, and has been recognised internationally for her leadership and impact innovation. Thank you very much, Tanya, for being here.
Thank you. I come in at a very good point after the last speaker because I am coming from the angle of technology development and innovation and why it's really valuable and important that we do that. I'm going to start with this, and I'm covering some of the topics that have been talked about earlier today, but also it's something that I think you all need to be aware of. So whenever I give a talk about women's health and femtech, I put this up. And it's a cartoon that is in a library in a university in Texas. We've studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody. Now, it's a bit facetious, it's funny, but it's also not funny because it's real. And just to talk about what I call the dark ages, and we touched on it earlier, women were excluded from clinical trials from 1997 to 1993. Just think about that. Any new drugs or products that were being developed during that period were not tested on women, yet they're all out there in the market and we were taking them, okay? What effect did that have? Big corporate companies decided not to create products for women or medications for women because they couldn't test them, right? That created a whole change in the system of developing women's health products. I have that little image there of the boardroom. This is the dark ages. Most boardrooms were made up of men. They were the ones investing in new products. I'm pretty sure that woman in there was just taking the notes or making the tea. But that also had an effect on the products that were developed for women. There was no money to invest. And then I move on to the next one, which is the man with his hands over his ears. Men do not want to talk about menstrual blood, abortion, miscarriage, breastfeeding, dementia for women in older age. They just don't want to talk about things that don't directly impact them, particularly at that time. And the other thing is, women, we're also responsible. We didn't want to talk about those things. It was taboo. We didn't discuss it with all genders. We didn't discuss it with our children. We just let things slip under the carpet and avoided that discussion. I'm glad to say, though, that we're in a new era, which I call the awakening, and that has happened probably over the last 10 years. So I start with a woman named Ida Tin, who did develop the first really good period tracking app called Clue. She started using the word femtech in 2016 because she actually realized that personally, when she went out to look for products and solutions to help her with her healthcare management, there were no products out there. And I think the first speaker today also touched a little bit on the fact that products have been developed with the standard male in mind. Crash test dummies, male, the big iPhone. They increased the size of the iPhone up to a point where women couldn't hold it anymore and they brought it back to a smaller size. But that bigger iPhone was developed so a man could hold it. We've moved on in Ireland. It's a particularly wonderful place to be a woman because we've done so much in that space. And I really say congratulations to our Department of Health and the healthcare HSC and people working in healthcare for what we've done for women. Women's Health Task Force, we now have like a whole new design of how we manage women with endometriosis. 5 years ago, people didn't even know what it was. We have menopause clinics, we have now public fertility, so we are doing an awful lot in that space, but there's an awful lot to do. And we mentioned Joe Duffy earlier. He started that discussion about menopause. I'm pretty sure everybody now knows about HRT and menopause, right? So in Health Innovation Hub Ireland, which is a national initiative funded by the government, we are supporting innovations being developed in Ireland. We're supporting our Indigenous industry, new product development and solutions. And we saw that a number of people were really interested in creating solutions in this space. Many of them were women. So we founded Ireland's first femtech ecosystem in 2022 to support the development of those products. I spoke at this conference in 2023. People didn't even know what the word femtech meant. So why is this an important area? And the world has changed significantly and technology is changing and we need to actually think about those things. A really healthy economy also leads to a really healthy healthcare system. But it's really important for us to realize how the world has changed. Women make up 51% of the population in Ireland and 48% of the workforce, so we have to focus on them. But also importantly is women drive 70 to 80% of all household consumer purchasing. That's a really important thing. So women are spending money on buying things, and that has made the industry wake up a little bit, and notwithstanding the comments earlier, there's an opportunity there for us to be supporting and involved in that. And also women are the primary care decision makers when it comes to their family's health. Having a problem with the technology. Okay, so where we are today, I think I've jumped ahead actually, sorry, one sec, just give me. So we have advanced so much in our discussion of women's health today that we don't just talk about menopause and fertility and treatments like that. We now discuss globally women's health under 3 different topics. We talk about conditions that affect women only, and you can see them there, and the image earlier of the women through their lifespan. This is what occurs to women as they go through their lifespan. So we have to deal with menstrual health issues all the way to bone health and dementia when we get older. And then all the things that happen to us normally as we go through periods, pregnancy, fertility, childbirth, breastfeeding, everything that happens after that. But also many women have to deal with things that go wrong along that pathway. So it's a huge area of focus. We talk about conditions that affect women disproportionately, and this is really interesting and a really interesting area for future work. Autoimmune disease affects women, 80% of women versus 20% men, autoimmune disease. Osteoporosis, obviously, as our hormones decline, our bones decline, it's a really big issue for women. Alzheimer's and dementia, people over 50, 75% of those are women. I know we live longer, but also it's a big statistic. What really gets me is UTIs, 30 to 1. And I think if you look at those GP visits and you count how many of those are women coming in because they have a recurring UTI infection, it's a huge area that has to be addressed. Now, it is changing a little bit with vaginal estrogen, but it is something that is probably causing a lot of those GP visits. And then we look at conditions that affect women differently. And we mentioned the heart attack in a woman presenting differently to it does in a man. So the man will have the pain in the chest, the fall into the ground, the Hollywood moment. Women generally don't have that. They might have a pain in their jaw, slight pain in their arm. In my mother's case, who did have a heart attack, she just had a little bit of back pain that actually manifested and got worse and worse until she realized what was happening. She probably Googled it using terms that came up from that CRE app. So these are really important areas that we need to keep looking at. Another thing that happened is Nature, which is a really big scientific journal, identified that the lack of research in women's health was really significant. And the amount of money spent on men's health, even in areas that weren't really burdens in health, was way bigger than it was for women. So the statistic we use at the moment, and it changes rapidly, it can be anywhere from 2 to 10, but even if it's 10%, less than 10% of the global health research budget is spent on women's health. And that is not okay, because we need to do the research to inform better treatments and better outcomes. So in Health Innovation Hub Ireland, where we help companies based in Ireland that are developing products, they're usually startup companies. A lot of them could be coming from healthcare, they could be small startup companies, they could be researchers coming out of universities, or the individual on the street that's seen a problem, a gap, and wants to do something about it. They're generally not coming in with the mindset of making a profit yet, but that may come in the future, and it's important. You can't keep products going unless you actually make money out of them. So we have supported more than 40 companies in Ireland developing products in this space, which is phenomenal for a small country like this. We are really punching above our weight when it comes to what we're doing globally, but also it's been supported by a much bigger ecosystem of researchers, clinicians, and the startup ecosystem in Ireland, including the likes of Enterprise Ireland. And the Department of Health and the Department of Enterprise are also really supporting this activity. So in order to support this more strongly in Ireland, we launched a Femtech report, which was the case for prioritising women's health research and innovation in Ireland. We were delighted that the Minister for Health launched it with us and the Minister for Enterprise, Trade and Employment. And in that report, we identified what was really needed in Ireland to catapult us into creating the best products to serve patients in the best way possible. And we identified 4 areas that need to be done. One of them was more money for health research, and I was delighted that the Minister for Health actually referenced this report when she announced 2 million funding by the HRB for women's health research. Looking forward to seeing the outcomes of that. We need more money to commercialise this research so you can keep these products going. We need to support those companies that are creating products. But one of the other things that we are trying, and the thing we're calling for in research is you disaggregate the data, so that's really important. If you do a big study on a population and you have 1,000 people in it, you need to look at your outcomes in terms of women and men as well as everybody. Really important for research. And then one thing we are going to do, and if anybody has loads of money in their back pocket and like to support us, we do want to set up Ireland's first Femtech development lab in a hospital with patients and clinicians all involved in developing those products and services. I'm not going to go through all these products, but if you're interested, you can download the report, just search Femtech in Ireland. But just to say, companies developing solutions in this space are across the country. I just want to give you an idea of a few of them. One of them is a company that's developing a product for vaginal atrophy. If you don't know what that is, that's where, because of a lack of estrogen, the cells in the vagina and the surrounding areas dry, basically. I'm not going to go into too much details. It is a problem that many women encounter. Yes, vaginal estrogen can ease it and is being used significantly in Ireland and in Europe. This is a non-hormonal device that women use. They're going through their clinical trials at the moment, and the results from this have been phenomenal. Women have, on the clinical trial, have said, I don't want to give it back to you, I want to keep using it. Newer Surgical is another group that have developed a product to create safer C-sections. So it allows the doctors to deal with the patient in surgery, and the retracting device pulls back the layers of the abdomen so they can get into the baby better. Less hands involved and better access. Significantly important when women BMI rates are going up, although they'll probably come down now because of Ozempic. But anyway, Perry, a really exciting company that has launched in the US first and will be launching in Ireland next year. Perry is a wearable device that tracks vasomotor symptoms and other perimenopausal symptoms. So women can go in and say, here is what's actually happening to me. I'm not imagining it. I think I had a hot flush last night. It's saying, no, you did. You had 4, actually. Or I didn't sleep last night, but it might have been too hot, or it might have been whatever. No, you didn't sleep last night, and you were awake for 3 minutes, 10 minutes, whatever it is, and this was your temperature. Now, I know we talked about data, and data is really important, but data security is really important, but data is really, really valuable. And I think Derek said the pace of innovation is going so fast, we need to keep up with it. And in Ireland and in Europe, we're actually in a good place. The European Health Data Space Act is coming out. We're going to be able to control what data is used for. The new AI Act, almost every single device that's been developed in this space is considered software as a medical device now. So it has to go through rigorous regulation. We will not be in a position to put apps that use data out on the market unless it's gone through rigorous regulation. And I think that's really important. The point is well made. But I don't think we should scare people away from using technology if the data that's captured in it is going to inform future and better health outcomes. I've only got 30 seconds. I'm going to move through the rest of them. Yes, we have hundreds of apps, and I don't want anyone else coming into me with an app because I'm sick of seeing apps, but they're valuable and they help people. And when I was growing up, we didn't have period tracking apps, and now everyone is using them, and it is giving people insight about their health that is valuable to them. Don't know why this isn't working for me. Okay, so I always use this as an example about why we should be supporting innovation in women's health and why the future is good. Anybody who's had a mammogram, they're brilliant. We should all be going for mammograms, and I encourage you to all go for them. But if you've had a mammogram, you will understand this image. It is not fun. You put your breast between 2 plates and you squeeze it, and you take the image, right? We have women with breasts of all different shapes and sizes. I'm fine, but women with small breasts, I don't know how they fit them in there. It must be hard. I know my time's up. I say that device was designed by a man, and no one ever pushed back and says there must be a better way to do them, but actually they did. So 2 female engineers came up with this device, which is basically like a bra that you wear and fits the size of your breast. And this is the one I like. This is a new product out on the market. You lie on it, and it does an image of your breast. That would be fabulous. And time's up, but I just want to say about the future. We talked about wearables, remote monitoring, artificial intelligence. And for me, I think the huge future area that we have overlooked recently is going back to novel biochemistry and diagnostics. We are getting new, really good evidence that we can now use blood tests to diagnose cancer earlier. In endometriosis, we don't know, we don't have it in the public system here, but in France they developed a product called the Ziwig EndoTest. It is a blood test you send off, and it gives you a 98% accuracy in diagnosing endometriosis. Currently takes about 9 years of surgery in Ireland. And the one thing that I want you to all look out for, because this is coming, continuous hormone monitoring. I know the skeptics in the room will say, what are you talking about? We will be wearing something in the next couple of years that will have accurate, continuous monitoring of our hormones. And the really smart people doing this in the world, or who recognize the gap in this space, and I go back to that lady, Ida Tin, in 2016, who started talking about femtech. She got the German government to put 40 million into this challenge, and that challenge is now open. And she is inviting groups from all over the world to address this challenge. And watch this space. The biochemistry is hard. The technology has been developed already, but the biochemistry needs to be worked on. But in 5 years from now, when your patients go into your GP office, you will know what their hormones are doing across their life cycle. That's it. Thank you.
Thank you very much, Tanya. I'm almost embarrassed if Tanya sees my terribly primitive Fitbit that I'm wearing at the moment. I know you went over, Tanya, but that really just lifted the enthusiasm for what's ahead and what the potential here. It's just amazing to listen to. So our final speaker today, I think, will bring that forward again and into some specific areas. So I'm very pleased to welcome Avril Flynn, who's the operations manager for BTL in Ireland. She brings a unique background spanning law, midwifery, and medical devices. She's passionate about women's health and well-being and is a highly recognised speaker and advocate, contributing both nationally and internationally to advancing women's health awareness and care. Thank you very much for being with us, Avril.
Thanks so much, Deirdre, and thank you to all the other really brilliant speakers. And some of what I'll be talking about today will echo many of those points, which is wonderful. I'll be speaking about the future of women's health using an holistic approach using advanced technology. So just to list out what I'll be talking about. So a little bit about BTL if people haven't heard of us, who we are. Women's health and wellness, how there is a great need, but there have been limited solutions up until more recently. And how women's health is not a singular problem to be solved, but it's actually an opportunity for looking at a holistic and wellness-based approach. And I'll be mentioning some of our really brilliant devices, namely Exomind, Emsella, MFEM 360, and looking at the solution to all of this. Instead of looking at these problems as individual, looking at a woman as a whole person, and when you solve one problem, the knock-on effect is solving the others, and using those solutions collaboratively can bring out amazing solutions for women. So BTL are originally a Czech company and started in 1993 providing rehabilitation devices. And we have spent the last 30 plus years creating, innovating, and designing many solutions in cardiology, rehabilitation, aesthetics. We acquired a robotics division in 2022. And then in 2025, we launched one of our more exciting and most exciting devices, namely Exomind, which I'll be talking a little bit about later. So women's health needs, it's hidden in plain sight. We are over half the population, but our health needs, as have been mentioned in the previous, by the previous speakers, really can come down the pecking order. And, why are the reasons they've been discussed by the other speakers, but I'll mention them again. The gender gap, there is just a huge gender gap in research, namely 5% to 95% or 10% to 90%, depending where you read. And as women age, our problems grow, and we are less likely than our male counterparts to actually seek assistance, or when we do seek assistance, to get the advice that we need. Perimenopause and menopause, people can fear them, and there's a lot of talk about them, but I would opine that this is a time for investment in well-being, both personally and as healthcare providers. So I'm going to talk about three main issues, one of the first being incontinence. So throughout, there's one of the areas that is more research than others, and there were, up until recently, recognized to be three types: stress, urge, and mixed, but now it's recognized that it's a much broader church, and we've included overflow functional reflex. It's more prevalent post-birth, and also can really raise its very ugly head during perimenopause and post-menopause. And this also has a huge physical, but a massive mental impact, and that again is often not considered in treatment options. Female sexual dysfunction, it happens, and it happens to many of us, but it is something that people can be very uncomfortable discussing, even with their healthcare provider. What is it? It's associated with a decrease in vaginal lubrication and arousal, and discomfort or pain during sex, with difficulty achieving orgasm. Wildly under-researched in comparison to its male counterpart. Viagra, it came, it saw, it conquered, but the female position has been really, really under-researched and underappreciated. And the estimates, again, because the research, some of it isn't wonderful, but good meta-analysis reckon between 12 and 64% based on physical activity might suffer at some point from sexual dysfunction. And again, menopause and postmenopause can be a huge trigger of this. There have been really limited treatment options. And again, it's one of the least likely subjects that somebody will bring up with their healthcare provider, talk to their friends, realize that there are solutions to it. And again, this has a massive mental impact. Mental well-being. It's a buzzword, but it's also a lived experience for a lot of women. And why are we particularly effective? We carry a huge mental load. Again, perimenopause and postmenopause can have an effect. And as we age, again, the problems can increase. In the 2025 Healthy Ireland survey carried out by the government, 56% of women experienced menopause or perimenopause, reported mood or rapid mood changes or low mood. 56% reported insomnia or sleep difficulties, and 53% reported brain fog or concentration problems. And then in a 2024 meta-analysis, about 32% of perimenopausal women experience clinically significant depressive symptoms. So it's a massive problem. So what do I suggest? BTL Advanced Technology connects the dots. Women's health, it isn't a singular problem to be solved, but it's a holistic opportunity for wellness. Women are not just a list of symptoms and deserve scientific excellence and the best possible care, the best technology. And how do we move on from where we are to a future of holistic female wellness? I would suggest this is a collaborative and collective understanding of the issues, combined with high-tech platforms, and that can equal transformative and very quick results. And I'll be talking about 3 of our devices, Emsella, Emfem, and Examind, and using these, suggesting to use these together to maximize the benefits for people that use it. Emsella, many of you may have heard, is powered by HIFEM, which stands for high intensity electromagnetic frequency, and it uses very, very strong but very comfortable technology and energy, and it penetrates about 7 to 10 centimeters upwards into the pelvic floor. It's a chair. It was designed for women initially. It's extremely comfortable. You remain fully clothed at the time. And what does it do? It induces more efficient growth of myofibrils muscle and creates muscle fiber hypertrophy and the creation of new protein strands, and increases muscle fiber hyperplasia. What it does is it's creating supramaximal contractions, which enable stimulation of the pelvic floor. So in a 28-minute session, it's the equivalent of doing 11,000 Kegels, which is kind of amazing. And how is this done? It's 6 to 8 sessions over a 3-week period, and it can help all types of incontinence and again improve sexual function. It's incredibly safe, it's efficient and very effective. And that's just an example of, compared to a regular common Kegel exercise, what the Emsella chair is doing. And as you can see, some of the results from some of the clinical evidence is amazing. Initially it was designed for women, but it is now being tested and used for men, and can also help with men post-prostatectomy when there's very few treatment options. Emfem 360, so this is an internal probe device. The treatment, unlike other ones on the market, this is a 360, so it uses not just one part internally into the vaginal wall, but it's actually treating the entire 360 degrees. The treatments are really short. They take only 8 minutes in duration, and it uses 2 types of technology, RF, radio frequency, and patented heat technology. And so it increases collagen, elastin, and hyaluronic acid within the tissues, improves elasticity, lubrication, and sensation, and targets urinary incontinence. And as I said, 3 to 4 8-minute sessions. And some of the research, again, is really interesting, particularly the last one, which is Irish research and the results are quite spectacular and really amazing for the women involved. And one of the things that we're passionate in BTL is research, so that we're currently undergoing increasing and more research into all of the areas and combining all of these technologies together. And I'll also invite you, we have a stand out in the main hall. I'll be there for the next 2 days with my colleagues. We're happy to go through the research in more detail and answer any questions that you have, of course. Come on. So ExoMind. ExoMind is a next generation transcranial magnetic stimulation device. So TMS is an older technology. It's been around for about 40 years, and traditionally it was used to treat major depressive disorder. What BTL decided to do is, instead of treating just major depressive disorder, what if we took it apart, put it back together, spent 8 years in research and development, but used it on the general population who might want to just increase their sleep, increase their mood control, and what they found was the results were kind of amazing. So it delivers controlled magnetic pulses in targeted cortical regions, and the region that we're talking about for this is the frontal cortex. And with intimate health and with sexual function, we know that the mental health layer has been missing in treatment, and if you do treat that, it can really improve the overall treatment options for everything else. So we know that psychogenic factors and stress responses often drive clinical symptoms, and again, post-delivery, menopause, and metabolic changes. So what we're suggesting is that ExoMind can target that missing layer and enhance the overall outcomes. So ExoMind was just launched, but we have some really good research, and it improves mental wellness and sleep and stress significantly. And again, really, really easy to use. You have about 4 24-minute treatments. It's totally painless and incredibly safe. So what am I saying? What does the future really look like? Well, it's addressing women's incontinence, mental wellness, and intimate health together using devices alongside the support of medical practitioners, looking after the hormonal aspect, but really using future technology, which is here now, to improve outcomes and the potential to radically improve outcomes for women in a very short period of time. So you could have somebody that comes in suffering with 3 different things that are all interconnected, and within about 6 to 8 weeks, they could have a radical improvement. Incontinence, sexual dysfunction, and mental wellness. We need to look at it all together and look at women in that holistic mindset. So women deserve advanced solutions that offer wide-ranging efficacy and treat multi-layered health and wellness challenges. BTL ExoMind alongside Emsella and MFem360 offer drug-free, patient-focused solutions that support emotional regulation alongside intimate health care. And together, these add the layers of support that many women need and offer technologically advanced approach to wellness that all women deserve. And at the end of the day, if we're really talking about the future, technology gives us the ability to not only help women, but help them at an incredibly high level and both efficient and safe. And my time is now up, so thank you so much for your attention.
Stay there.
Yeah. I'll give you that. Sorry, Deirdre.
No, sorry. Thanks very much, Avril. And I think what comes across in the way Avril speaks is just that ability to break down the barriers to an area that does need to be spoken about. Certainly as a GP, I know that you can see the relief in somebody's face when, perhaps they bring it up, but actually if you bring it up and allow them the space and the comfort to be able to discuss something that, goes to the whole heart of, as you say, intimacy, but just things that aren't talked about. So I think we have a few minutes for 1 or 2 questions. So I'm going to move back over to that side, if that's okay with, I'm getting the nod from Tom. So that's great. Thank you very much, everybody. And as I say, we moved across all things from the past to the present, to the person, to the technology, and onwards. So that was a great conversation. Sorry, I just move around a little bit. I was just going to start, Linda. I was interested in when you talked about workplace, and I suppose what underpins all of the conversations we had, and each person spoke, was yes, it's about healthcare. Yes, it's about people, and that's what Future Health is about. But I suppose there's a huge economic background to all of this, and you spoke about workplaces and the differences for women that you see through your occupational resources and services. You want to tell us a little bit more about that?
Yeah, so I suppose when we've done some research through quite a lot of our corporate, I suppose, population is looking at the challenges that, I suppose, specific to women that women face in the workplace. I suppose a lot of that is that kind of, a lot of it would be, through the different stages of the reproductive cycle. Stuff that would come forward very clearly would be things around like at work adaptations, for menopause. So for example, the temperatures, even things as basic as the temperatures that are set in offices were traditionally set based on the male physiology. So they probably run a little bit warmer, you know what I mean? So then if you have women who are getting vasomotor symptoms, you know what I mean? So there's things like that. And a lot of it is kind of, once you have an understanding, what we found is having that understanding allows you to help inform employers so that they can do things differently. So certainly things like around kind of, different life stages. So menopause would be a big one, but fertility would be another one, you know what I mean? And I think the recognition from an employer perspective is that if they can do that, they can keep women in the workforce for longer. You know what I mean? So there's that kind of, nowadays, like workforce is a huge challenge across a lot of sectors, so trying to be able to attract and retain really good employees is really important. So having I suppose a women's health kind of mindset in terms of how you set up your kind of policies and so on is really important. So a lot of companies now, and certainly in VHI, we would have helped some corporates with this, would have like specific policies around menopause. In VHI now, we would have one for our colleagues where people are entitled to menopause leave, a certain amount of days that they can take without having to have any kind of doctor's notes or anything like that, just to be able to accommodate women. And I think that when you do that, I suppose you keep people in the workforce, it's a more kind of productive setting because you're supporting people. But there's the economic impact of that is huge from a productivity perspective as well.
Of course, the expansion of that, and I might come back on other speakers with it, is that if you're providing a flexible workforce for your women, then it should be entitled for the men as well, and the men benefit from it. I had an example a couple of years ago where somebody coming into a partnership wanted extra study leave. And at first it was seen as, why would you do that? And then suddenly everyone realised, actually, that's a good idea for everyone. Let's all do that. So as you say, if you provide flexibility, if you have a mindset to do that, it works onwards. Yeah. Laura, I might bring us back to the 29 million, which is our favourite number. And I think it's important for us to say in that the 29 million is across general practice in general. It's about 21 million provided by GPs. And we must remember the remainder of it, the 8 million, is provided by our practice nurse colleagues who are hugely important in the delivery of women's healthcare in practice. Again, through antenatal care, vaccinations, and all the way along. So it's very much a team-based approach. But if we're going to talk about it, so we've got 26 years of 29 million consultations. If you had finance and all of the regulation that you need to harness that data, have you any idea what it would tell us or what we would use it for to change, to improve? Have you? I may be putting you on the spot a little bit on that one, but what do you think would come out? What would we see?
I think trust would definitely come out. I think it would come out. I think that whole piece of the multi-generational family relationship would be demonstrated by that data. We don't just know individuals, we know whole families and multiple generations of them. So I might be providing palliative care for somebody in a family, but I'm also seeing their daughter with her first period that's causing some problems, So I think it would show that. I suppose I'm not a data analyst, and I want to acknowledge that, and I'm certainly not an engineer, and we're very lucky in the college to have a phenomenal person who has an engineering and medical background. His name is Mike Williams, and I know that there's a couple of people going around using the term physician ears, which which is a fabulous term, I think, because the more of those kinds of people we have in medicine, it allows us to see our blind spot. But harnessing that data is absolutely vital, and allowing us, not so much allowing us, but enabling us to harness our data, and the small little chinks of that I've seen and witnessed. So, for example, at the moment I'm working on a report to do with maternity care. And as you know, GPs have been providing combined care with, along with our hospital colleagues for many, many years. Harking right back to the Noel Brown story you kind of reminded us of earlier. And I'm really seeing the value of what we do in that, but what it's also enabling us to visualize is how lacking in investment that is. That needs to be invested in. There's very little or minimal investment been in that in the last 30 plus years. And so what's happening is because there's been minimal investment, our ability to expand upon the care and the complex nature of that care is becoming more difficult. So I'm just seeing the chinks of it, but I would love to work with more people like Mike, who works with us in the college, to enable us to expand upon that, because I think there's huge gains to be made there. Yeah.
I think
Thank you.
Tanya's going to come in on
Two
that.
things, and I think when you started speaking, what struck me is that you said, I know her mother and I know her sister, right? But if you take that situation and just say I can't remember the name of the girl that you pushed.
Helena.
Just say Helena had moved to Dublin and was in college in Dublin and you're based somewhere else. That's what harnessing the data can do, because if you can set up a system that allows you to say, kind of match the family members and the family members' diseases or conditions or whatever they've had, that will inform another GP. But